computer. So it is currently about 9:05 on May 21st, 2021. We're going to do the review session requested for this day. For you guys that paid attention, I have the review session scheduled about every other Friday. And then as we get closer to the exam, I have it scheduled for every Friday. If there are any additional concerns where you need extra review sessions, I want to stress this again, please reach out. We'll make it happen. We'll make it happen. Don't stress out if it's something you're freaking out about that you're studying, you just aren't getting, and you don't want to wait till the next review session. Reach out to us. I'm going to let Dr. O'Neill talk for a few seconds here. Make her the spotlight and let her talk for a few seconds. Then we'll get going on the review session.
Yeah, I won't keep you guys very long. I obviously, this is a team effort. Mr. McKeever has been so important in this process because not only is he really passionate about exam prep, he also is really, really excellent at it. And so he's going to do a good portion of these, but I plan on also, jumping in. We're going to also see about having some of our other faculty team join us too for their content expertise. So you guys will see a variety of faces. Additionally, though, I really feel it's important for you guys to feel connected as a team, like we mentioned before, the last week that you guys were on campus. So I'm actually going to open it up to being on campus now that we have some leeway with the COVID regulations. I know you guys are very familiar with keeping yourself safe. So plan on having a presence on ground for some of these. To incentivize it, I'm going to do a couple different things. I'll let you guys know, in addition to some gift cards, feed you guys to make sure you feel comfortable. Of course, we wouldn't eat it in front of each other just because of COVID safety restrictions. It would be something that we could space ourselves out and do. But we are very, very invested in you guys doing well. Okay, I don't want to put any undue pressure, but we are definitely looking for your guys' cohort to perform well because there are have taken a look at the previous cohorts for 2018 and 2019 and felt like there was a decline, which was, of course, before I came on in leadership, before several of the faculty joined us. But, that's neither here nor there. We want to focus on you guys. So don't be surprised if you guys get invites for coming on campus. Additionally, there will be some additional test prep resources that will be coming down the pipe just to really make sure that you guys are prepared. We don't want to bombard or overwhelm because the score builders did an excellent job of, and you guys have a schedule that you've established. Each of you met with me, Mr. McKeever, and we've checked the schedules. Your goal is, of course, to keep to that schedule. And then our goal is to hold you accountable and help you get as prepared as possible. So there is definitely going to be some, you know what, that's a good question, so kind of we'll let Mr. McKeever talk about that. If there is an additional session, though, that we need to present, once again, if we need to do something for an evening in person, we can absolutely look at that, especially as you guys get closer to testing. I want to make as many options as possible. I was even going to possibly add a doodle poll for June, maybe to kind of see if anybody needs additional time and or alternate time, okay? Because I want you guys to feel comfortable coming to campus. I feel like for most of you expressed that being in person is the best way for you to learn. And so therefore I want to make sure we feel comfortable with that as well, because I don't mind being there having you guys. I really enjoyed having you guys the last couple of days. So so not to put undue pressure, you guys I know are already feeling it enough, but just know that we are also as a team really counting on, and I know you guys are going to do well. So that's just my confidence in you guys has not wavered. This cohort has been through so much together, as well as your staff and faculty, that we are kind of all in it together. So we're in one team going all in on you guys, and we want to make sure you do well. So that's my 2 cents. If you have any questions, you guys know you can email me, text me, and we'll go from there. So.
All right. So so a good question there, Sakina. We're open to changing. I just scheduled it for the morning right now because that was when I did the original poll when it was preferred, but we can do evening sessions, we can do afternoon sessions. I mean, it may not always be me. Yeah, morning works well, right? Obviously, it may not always be me if we do an afternoon session because it may be Dr. O'Neill while I'm teaching or something like that, but we definitely can work out whatever everyone needs. Let's go that way. So yeah, morning works really well for me. It's just whatever everyone else needs is kind of where we're at. So we will do what we got to do is basically it. All right, I'm going to share my screen here, get myself set up right. So I have my chat set up and My picture set up.
Mr. McKeever, I think we have a cohort 12 student in.
Yeah,
Not
she
that
asked
she's
if she
not
could sit in on it, so it's
No
okay.
problem. I just want to make sure. I don't want her to freak out that this is something she's got to do right now.
Yes, I told them yesterday if they wanted to sit in on it, they could sit so they could start
Hey,
to see, because
they
they're
are
the ones
welcome.
getting ready for testing soon anyway. So, yep.
They are welcome. No problem.
All right, so we're going to do a review session today. So I put a couple lists together. So I started doing, I did our test information session I usually do for my first review session with you guys. So I'll go over that first. The topics that were requested this time were electrical stim, ultrasound, patho, capsular patterns, muscle actions during gait, forward head, UMN versus LMN, and then synergy patterns, which, believe it or not, UMN versus LMN ties really into the synergy pattern. So we'll get there in a second. It's funny, I actually picked Dr. Reskin's brain a little bit last night with the synergy patterns, and she was just super duper like tickled excited because she loves the primitive reflex theory. So she was just tickled pickled just talking about it, and I had to trim it down a little bit because she wanted to go way far into it than more than we need. So just to kind of review, I know score builders went over this, but I really want to stress and kind of hit this again. The test is broken down into several categories. It's broken down into categories of work and categories of bodies, right? The work categories are physical therapy data collection, pathology, interventions, and non-systems. The body systems are cardiopulm, musculoskeletal, neuromus, integ, and then other systems. So the way this works is you may get a question that qualifies for multiple of these. So you might have a cardiopulm pathology question, or you may just have a straight pathology question that doesn't qualify for a body systems. So your pathology question that may not qualify for body systems may be about COVID, right? It may be specifically talking about preventions for COVID and how to, and again, if you get a COVID question, you're pretty confident that's going to be a preview question, but I'm just using it as an example, as an easy one. So it may ask, what are some common ways to prevent transmission of COVID? Washing our hands, social distancing, masking, stuff like that. That wouldn't fall into a body systems category. But you may get a question, I'm just going to use COVID again, that says that the best position to place a patient in order to provide airway clearance to the lungs, which now we're talking cardiopulmonary, for COVID pathology is prone. So in that case, that would be a cardiopulmonary question as well as a pathology question. So that kind of is the way the test breaks down. The questions are broken down in both being data collection question and false neuromuscular question, which I just covered. The questions are further broken down by levels of question. I know that the score builders instructor did a lot better job of this than I do it, but this is the way my thought process works into it. So if they label them something different, please excuse my way of labeling. There's level 1s, level 2s, level 3s. Level 1 questions are the core questions. These are your basic foundational questions. These are called what I call quick recall and are also worth the least amount of points. I call these the duh questions because these usually get everyone. For whatever reason, it's usually the level 1s that get you. These are the biceps have how many origins question, right? Or the biceps insert on which of the following bones type question. Those are those ones that should be just boom, done, in and out, and it's easy. But for whatever reason, when we look at these questions, we're like, hey, wait a minute, they're trying to trick me here. And we get stuck on these questions just because we overthink them. If it is that simple, it just is that simple. That's just the way it is, right? Level 2 are what are called synthesis. I can say this word, synthesis question. This is where we start applying knowledge. So now instead of talking about the biceps, they're going to talk about how the biceps might interfere with an activity, right? So you're starting to integrate the application of the knowledge. These are the second most highest point questions, right? So level 1s, lowest, more points for level 2, and then the level 3s, which are the interpretation questions. These talk about now you have a patient that has a biceps tenosynovitis, and it's interfering with their ability to work and blah, blah, blah. Which of the following, modalities might be the most appropriate to help with this? Those are the highest amount of points. So those are where we fully integrate your ability to do stuff. The scoring system originally went from 450 to 800. Now I've got to change that. I didn't realize I didn't change it. It now goes from 400 to 800, which I'm not exactly sure what those extra low 50 points entail, but whatever. With a passing score being 600. The average number of questions correct in the last exam to get 600 was about 98 out of 150, or about 63.5%. So this is what I want to kind of de-stress you guys about. You can do a 65%. Like, I'm just saying, right? And the average person that ends up failing the exam, unfortunately, usually ends up failing it by less than 4 questions. So that's what I kind of want to say, is you guys can do this. This is not an impossible task, right? One person may require 98 to pass. Another person may only require 90 based upon their level of questions. And you won't know that really while you're at the test. They have the ability to let you know the score right off the bat, but they do assess every single test that comes out of there. They check them all against, a database to see if there's any cheating, anything abnormal. So it does take about at least a week until you get your score back. The test is divided into 4 categories of equal portion, or 4 portions of equal 50 questions. After every section, it closes that previous section. So once you take questions 1 through 50, it will say, are you ready to submit section 1? And once you submit section 1, it's gone. You can never go back to it. It's history. You're on to section 2. I know I said that the test is only out of 150 questions, right? And you did take math class, and 4 times 50 is 200. But there are what's called 50 preliminary questions, right? These are questions that are in the future. So these are what we call test questions. They're used to judge the knowledge of newest information. Right now, a lot of COVID-19 questions are popping up in here. In between section 2 and 3, there's a scheduled 15-minute break. Take it. I know some of you are going to be all excited and just want to get through your test. I'm telling you, get away from that desk for that 15 minutes and take your break. Get out of your chair, go to the bathroom, splash some water on your face, stretch your legs, right? Don't skip your scheduled break. You also can take a break at any time during the test. If for whatever reason your bladder decides in the middle of the 3rd section that you've got to go to the bathroom, you can take a break. You just lose testing time at that point. So that's why you kind of got to get into that routine of sitting for at least that 4 hours, and prepping your break time so that maybe in the middle of that 4 hours, you can actually take a bathroom break. It takes a little bit of training of your body to do that. Just like when I was in the martial arts, training my body to sit through a 4.5-hour black belt test was rough, but there are ways to do it. You've just got to kind of get your body built up to doing it. Question marking. You can mark questions for review, but which ones should you mark for review? The best option is to divide your questions into a couple categories. Questions that you know the answer to, don't mark these. If you're like, oh, I know how many insertions the bicep has, you don't need to review that. Just answer it, move on. Don't overmark your questions. Excuse me. I've had a student before that said, well, I know the questions were 50 questions, but I marked 45 of them. Why? You shouldn't need to mark all 45 of them. You should know them. You shouldn't want to review every single question in the section. It will kill your time if you do that. There are questions that you're confident that you got the right answer to. Don't mark those either. Your gut's usually right. If you go back and review them, you'll probably change your answer, and that'll cost you points. Don't change your answers. Changing your answers kills you. And then there's the questions that you don't have the foggiest clue on Mars about. Those are the questions you mark. And those are the questions you come back to. Because those are the ones you just don't know the answer to, and you may have to review. So when you get those type questions, it may be talking about the specific version of an MRI, whether a weighted MRI or a non-weighted MRI are best to view a cervical disc. You may not know the answer to that. That's the question you mark. Don't spend time dwelling on the question. Mark it, pick one of the answers, mark it, and move on. what happens is, if you dwell on a question, you will ignore the next about 3 questions. If you ignore the next 3 questions, that costs you points. So go, I don't know question 20, that's okay, I'll come back to it. Move on, answer 21, 22, 23, 24, and then come back to it at the end of your section. The more you mark, the more time you'll spend going over them. Ideally, in a section of 50 questions, you don't really want to mark more than 10 questions. Get more than 10 questions, that's when you start getting into the I'm marking way too much. Now, there are multiple testing resources out there. We've given you all kinds of them, and Dr. O'Neill and I are going to be researching a bunch more. So please understand that. We've got Scoreboard, which did, you have Therapy Ed. There are plenty of other test taking resources out there. The main thing here is the PEAT is the most correlative scoring that applies to the NPTAE. Usually when you get greater than 600 in PEAT and you did the test fully on your own, you're likely to get a 600 plus on the PEAT. I used to say 600 plus is a good to go, but right now I'm just saying with the way the changes in the testing scoring has gone, I say 610 is definitely a good to go. If you score less than 600 on the PEAT, you may want to reschedule, and we'll cross that bridge when we come to it. The test itself is broken down into a couple parts on the national exam. With your questions, you'll have the item, right? This is the whole multiple test question. This is the part that nobody likes. This is where you have to read through the whole thing. That's the item. In the item, there is the stem. The stem is your actual question, right? I've given you a couple questions on your test where it's a book that you're reading, but it may only be the last part of that sentence. That's your question. That's the stem. That's what you're looking for. So it may be this whole long question about this patient that's going up and down stairs and blah, 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 blah. And you're looking through it, and you're looking through it, and it says, what is the required range of motion at the knee in order to go up and down stairs? You just read 40,000 words, well, not 40,000, but a bunch of words. And really it's stemmed down to that couple like 7-word part. That's your stem. And then you have your options. Your options are your answers. There's the correct answer, and then there are distractors. The distractors' jobs are to make you feel like you don't know what's going on. Right? Those are the ones, and sometimes they're really good. That's when you get those like, is it A or is it B? Or is it A, B, or C? They're designed to be that way. Good, sorry. Remember, on the NPTAE, it's not always the most aggressive treatment you saw in your clinic, right? And we did, I know, I've been in the clinic, I've seen some pretty aggressive treatments. It's based on the safest treatment for the patient. If there's a question and it's got a gait belt on it, it's probably the right answer. Right? Safety is the same thing, right? With something like autonomic dysreflexia, you're looking for stand them up, check the catheter. If it's talking about the most safe device for gait training, parallel bars are in it, there's your answer. It's looking for the most safe or the safest treatment for that patient. There are several types of mistakes you'll make while taking the exam, and they can be summed up in a couple of groups. Knowledge-based. Yep, yes, didn't know the answer. You're going to have a few of those. It's common to have knowledge-based questions that are just, I didn't review that enough. It happens. It happened to me on my boards. When I got a knowledge-based question, I was just like, look, I just don't know this answer, and it's B. I don't know. All right? Choice-based answer. This is where you know the answer, you have the knowledge, but you picked the wrong one. I chose the wrong answer. I didn't read the question thoroughly enough. Oh, why did I pick that one? Right? You've all done this when you reviewed an exam before, right? You're sitting there and you look at the exam, you're like, oh my God, why did I pick that one? It was B. That's a choice-based mistake. And then test-taking mistakes. These are the ones that will kill you. This is, I messed up my choices. I circled B on my paper, like when we were back in class, but I filled in C, but I really meant B. Totally did not read the question, like, despite my exceptional knowledge. This is where you miss those bold not and accepts, right? Where it says, which of the following is not an effective treatment for lateral epicondylitis? And you go down and it's like, oh, right? Then you're going down there and you're like, oh, there's ice massage. Ice massage treats lateral epicondylitis, and it says not a treatment for epicondylitis. Don't mess those up. Or The other test taking mistake is I changed my answer after my gut said I had the right one. Oh, B is the right answer, but C looks really tempting. I'm going to change it to C. And then it comes out and the answer is B. And you're like, daggone it. The mission, should you choose to accept it, is to review your exam, look at those questions you got correct. So when we do those PETs, and see if you've made a knowledge-based, choice-based, or test-taking-based error. We want to minimize all errors, but the goal should be specifically to minimize test-taking errors, because those are the ones that are going to cost you the exam, right? We don't want you making those kind of exams. You don't want making those type of exam errors. If we can minimize those, again, you can pass the test. 98 out of 150. You guys can do this. So I have this form here after we take the, like some of your practice exams. Use this little form here. This will help you. So how many questions you get right on the exam? How many questions you get wrong? And then go through each of your errors and look, did I make a knowledge base? I didn't know this answer. Did I make a choice base? I picked the wrong answer even though I knew the right answer. Or did I screw this one up and I chose the wrong answer even though I knew the right answer? Test taking. So use this. I honestly, when I was in school, one of the first classes I took in my psychology class was test taking, not test taking skills. It was psychometrics, which is the numbers of testing. And I had this form, and from then on, every single test I ever took in my life, I use this because I go back through and I really try to minimize those test taking mistakes. And it's always helped me to look at this and go, man, how did I get 15 test taking mistakes on this test? What was I thinking? And then I can go back and analyze and go, oh, well, you know, the neighbor's dog was barking the whole time I was taking the test and my phone rang 5 times. You know, those distractions affect your test. The good news is when you're sitting in the cubicle taking your national boards, you got none of those. You'll have headphones that block out noise and your phone is not going to be with you. So that's the good thing. Trust your gut. It's probably right. I'm going to speak from experience. And again, I was the aberration. Do not follow my example when taking the test. I graduated on a Tuesday. I was eligible to test on a Thursday. I took the test on a Thursday. That was way back when we could pick our own test date. I went in, I sat down, and I got a 793. I didn't really prep. I prepped while I was on my clinicals, but I didn't really prep in advance for it. I did really well. I also have a lot of experience taking tests, right? So don't follow my thing, right? But I know one question on that test, and I'm 100% sure of it. I didn't trust my gut, and I changed the answer. And I swear to this day, that was the question that cost me my 800. I'm just saying, it probably was. I don't have any proof for it. It's just my gut again. My gut was right on the answer. I'm going to say my gut was right here. Trust your gut. It's probably right. Don't change your answer unless you know you've made a test-taking mistake, right? Focus instead on moving ahead and getting decisively through your questions. Don't dwell. Yes, question 4 is hard, but if you spend the next 7 questions dwelling on it, you'll have 50% of them as test-taking mistakes. Mark it or complete it and move on. Just accept the fact that there's going to be some that you don't know. You know, even Dylan's going to miss some questions every now and then. As amazing as he is, he'll miss some questions. So we've just got to make sure we all do that. So let's talk about eStim, because this is something, I got a couple of them I went through and I kind of broke it down, right? We'll start breaking down just the different ones. So TENS, obviously, and IFC are both used for pain modulation and swelling control. They can be used for desensitization of nerves. And there is some recent evidence out there that shows that it does increase localized blood flow as well, which kind of we knew, but they're just realizing now that it might actually be more efficient localizing blood flow. The real interesting one that I just saw the other day that I read an article on that they're doing some research on is TENS and IFC may be starting to be used for vagal nerve desensitization for patients that have those problems. So that could be an interesting thing sometime down the future, but not now. Remember that TENS is direct current and IFC is alternating current, right? How do you know that? Well, TENS unit's a battery and IFC is plugged into the wall. Now, I have somebody that comes along and says, well, I've got one of these newfangled units in my clinic that does IFC on a little box. Great. That box actually has an alternator in it that converts it from direct current to alternating current. You can do that. right? The pad setup. Remember that with tens, it's I formation, right? They should be in line. So channel 1 is in line with channel 2. They can be in line like this, right? That's still I formation. The only time you really don't want that in a linear pattern like this is across the spine. They should be on either side of the spine if you have the spine. Whereas with IFC, X gonna give to you, right? It's in cross formation. The pads are set up in this formation so that channel 1 and channel 2 interferential current with channel 3 and channel 4. They form that X formation. The theory is the wider the pads, the deeper the penetration. That's the theory. I know that's what the book says. I don't know that I've ever really felt that myself using STEM on myself, but that's the theory on it. And so we'll go with what the knowledge says because they researched it and I haven't. With acute pain, right? Oh, look, I've got acute pain. With either TENS or IFC, you have a high frequency and a low pulse width, right? And it's going to work on the gait control theory. You want it to rapidly hit so that it's more like rubbing your head. High frequency, low pulse width. Remember, especially in the clinic, once you guys are done, IFC, you don't have to adjust the pulse width because it automatically does that for you, right? The machine is smart enough to know, oh, you set a high frequency, we want a low pulse width. But with TENS, you do have to adjust the little knobbies in there, right? But the gait control theory is that just closing the gate of pain, right? You're rubbing it, and that's what the high-speed TENS is doing. It's just kind of rubbing it and blocking that pain reception. The intensity should be set to the patient's feeling. So if you get a question on your boards that's talking about, well, what intensity for TENS or what intensity for IFC? Well, with acute pain, it's just until the patient feels it. Again, it's so that you get that rubbing sensation going on. Versus chronic pain, right? Chronic pain, we invert it. So we get a low frequency and a high pulse width. We want something that's beating at a ability for the muscle to contract, and we want it to hit for a longer period of time. But even though we're talking microseconds here, you're not going to really see that, but we want it to hit for a longer time. This operates on that noxious stimuli theory or the endogenous opiate release theory, right? And we're going to get a muscle twitch or a muscle tetany out of this, right? This is where we want the muscles to dance a little bit. And again, remember when we talked about this, I'd said that I usually tell the patients that chronic pain TENS and chronic pain in IFC is just a little bit uncomfortable. It doesn't feel the best. Well, we're trying to get noxious stimuli to release opiates in the body to help with pain relief. IFC also has a scan and a sweep percentage. The industry standard is 40% scan or sweep. And you're not going to get a question likely on the boards about this. If anything, it might ask you what the standard is for industry, and it's 40% scan. That's what all the machines are set for. You can adjust the scan based upon accommodation, and that's something that you learn in continuing education. Why do we use a 60% scan versus a 40% scan? Or why do we use an 80% scan versus a 40% scan? One of the wound care courses I went on talked about in order to relieve swelling control, you want between an 80 and 100% scan in order to allow for more of the fluid to move. Again, that's not basic knowledge. That you don't have to worry about, right? And then pre-mod, which is pre-modulated IFC, the only difference between pre-mod and regular IFC is it's 2 versus 4 pads, right? IFC and TENS are 4, right? Pre-mod IFC is 2. That's TENS and IFC in the nutshell for your boards. Russian versus VMS burst. So Russian used to be called AMS burst versus VMS burst. Now we call it Russian. I still, to this day, never actually, I know there's a reason why it's called Russian, but Russian is amplitude modulated simulation, modified simulation, and VMS is voltage modified simulation. So it just determines what the intensity is going to be measured on, right? We know that amplitude from physics is a little bit more bitey. That's why when specifically when I'm working with kids, I tend to do VMS burst versus AMS burst or Russian, because VMS burst is a little less bitey than Russian. And those of you that felt it, Russian can definitely be a little bit bitey, right? It doesn't always feel the best. Some of you are like, I love Russian. Yeah, you're the weirdos. I'm just joking. It's neuromuscular electrical stimulation used to re-educate muscles. Key thing with your boards, and I know that I've seen this question pop up a couple times, it cannot re-educate denervated muscles. It will not work on muscles less than a 1 manual muscle test grading, right? If the muscle is 0 out of 5 and it's a dead muscle, can you get the muscle to move? Absolutely, right? I've done and you can actually do it on a fresh cadaver that you can actually get the muscles to contract even without, there being neurological function there because you're sending the signal for it. That doesn't mean it's fixed. It's not doing re-education at that point, right? And will we do that sometimes with patients that have something like foot drop or wrist drop? Yes, but that's not causing their muscles to fire on their own. That is purely the stim doing it, right? So it will not re-educate denervated muscles. The pad set up for Russian, the pad should be set up so that at least one of the pads is on the neuromuscular junction of the muscle as possible, as close to the neuromuscular junction as possible. How do you know where the neuromuscular junction is? Most neuromuscular junctions are right at the muscle belly. So the mid muscle belly. So if I'm looking, brachioradialis, there's my big old brachioradialis, right? All right, so there's my main mid muscle belly. That's probably where my neuromuscular junction is. And actually pinching it, I can actually feel it's uncomfortable and maybe tingle a little bit. So we're going to put at least one of those pads as close to that neuromuscular junction as possible. The second pad should be placed somewhere else along the muscle belly or the tendon as possible, right? Something like wrist drop where you've only got the wad up here that you can put it on. The other one should be placed somewhere along the tendon so that it doesn't affect as many muscles around it as possible. We all have done this with tibialis anterior, where the tibia is kind of a thin muscle at the top. And if you put it a little bit lower, you end up hitting those peroneals and you get a lot of eversion going on in the foot, right? And for some patients, especially working with kids, it can get really challenging to just get tibialis anterior. You may have to go to really tiny pads for it. Settings should be set as appropriate for PPS. Lower frequency simplifies or simply fatigues the muscle slower. Higher frequency fatigues the muscle rapidly. Cycle time is that on-off time, right? 10 is usually a common one, but ideal times has been shown for 6 to 10 seconds on, with an off timer being at least 5 seconds or longer. So you want to give the time for the muscle to relax, right? So if I'm doing wrist drop, I want it to pop up for 10 seconds and then relax for at least 6 seconds, right? Ramp time, 5 seconds is common. The shorter the ramp time, the more the patient gets off a solid tetany contraction. Ideally, according to most of the research, should be less than 4 seconds. Right? 5 seconds is just kind of the lowest setting that's on the machines usually. When you lower the ramp time, more of that cycle time is spent in full tetany. Duty cycle, 50% is common. There's not a rhyme or reason that I saw for this in the book, so I looked in multiple of the STEM books. I don't think there's a specific reason why to adjust the duty cycle on that. Intensity is set to achieve muscle tetany. So this is where it gets uncomfortable. They're going to actually get that full contraction going on, right? High volt is a monophasic current with twin peak forms of short duration used in wound healing. So the main thing that you'll know about high volt when it comes to the practicals or the boards is that it's used for wound healing and swelling reduction. And usually the wound itself, the anode is applied to the surrounding area of the wound in order to increase positive potential and speed along wound healing. So that's about all you need to know for high volt for your boards. Microcurrent is a monophasic or biphasic square waveform with low frequencies used for healing parameters. It's used to generate a subsensory level stimulation. So that means that the patient's usually not going to feel it, right? And it's to facilitate micro muscle contractions. I always love that. Like if it's not, you don't feel it and you can't see it, sure it's doing it. It may be used in pain treatments when other modalities don't seem comfortable. We've used it in patients that have really, really bad compartment syndrome, that they can't tolerate anything touching their skin. Well, then we can use microcurrent, which not a lot of the machines have, to help relieve some of that pain, maybe stimulate some of the healing in the area when other modalities might not work. And then we have biofeedback, which is the micro detection of action potentials at the neuromuscular level to help facilitate the contraction. So biofeedback, you're not actually firing any stim into the muscle. Biofeedback is going to detect the patient's own contraction and let the patient know, usually via audible or a visual signal, that they're actually contracting. So it's going to detect the electrical signal. You can combine it with VMS or Russian so that when they start firing, the VMS and Russian helps them fire as well. So you can do a biofeedback Russian combo. It's to help improve the contractions and then also improve the relaxation. So if you've got somebody that's got spasticity, you may use biofeedback in the reverse. Instead of it firing off when they're fully and lighting up and beeping when they're in full tetany, you use it when they relax off. So it teaches the patient how to try to relax that muscle. I believe that's all I put in for Ionto, right? Ionto is the last one for e-stim. And this is usually the one, and I actually got 3 questions about this via text the other day. This is usually the one, for whatever reason, you guys freak out because you get one question Ionto and you forgot Ionto. Ionto is the transdermal delivery of medication via e-stim, right? You have to know the polarity of your medication prior to application. Now in physics, I gave you a chart that had the polarity of all the medication. In your score builders book, there is a chart that has the polarity of all your medications. If you have a negative medication, such as lidocaine, you need to put that under the negative pad because you are going to drive it, right? Negatives repel each other. So if you put it on the negative pad, the negative is going to kick on and it's going to push the medicine into the patient. The normal rate for it is 40 to 80 milliamp minutes for your boards. The important number to remember is 40 milliamp minutes. That's the standard treatment time charge for a iontophoresis thing. So 40 milliamp minutes is your thing. So that is your, when you're looking at, if you look at it from a math standpoint, 40 milliamp minutes, you're measuring your milliamps times your time. So if 40 is the standard and you set it at 4 milliamps, the time's going to be for 10 minutes to get 40 milliamps, right? So 4 milliamps times 10 minutes equals 40 milliamp minutes. The lower the current, the less chance of reaction. The higher the current, the more chance of a reaction, right? We can do something like 10 milliamps. If we do 10 milliamps, now they only have to be on it for 4 minutes to get that 40 milliamps, right? But we have a greater chance of having a reaction to that. So how do you prevent reactions? Well, you lower the milliamps or conversely raise the time. Because if you raise the time, milliamps are going to go down, right? That will prevent a reaction. The other option you have to help prevent a reaction is use larger pads, right? If I have a pad here that's 1 inch, say this is a 1 inch pad, all my medication is being delivered in that 1 inch. If I replace that with a 4 inch pad, now my medication is spread over a larger area. That will help prevent a reaction. So the main ways to prevent a reaction, right? Because that'll be one of the questions I guarantee you'll get eventually, is to increase the time, decrease the milliamp or intensity, I'm going to spell this wrong. I'm going to be embarrassed. Or increase the pad size. Or ultimately, the best way to prevent an adverse reaction with Ionto is to increase the time and increase the pad size, right? But let's say we have something like lateral epicondylitis. We may not want to increase the pad size too much because then the medication is not going to be as focused on the area we have, right? Now, if I'm working on something like plantar fasciitis and I'm using acetic acid, sure, I can put a pad that covers the whole bottom of the foot and still be fine. It's just the way it is. The other, so I talked about up here, the polarity of the charge indicates the same charge electrode. So like we have lidocaine. Pretty sure lidocaine's a negative medication. I'm going to embarrass myself if I'm wrong. So here's our negative pad, right? That's where our lidocaine's going to go. The positive pad just goes somewhere else, right? So if I'm doing lateral epicondylitis, ideally, yeah, there's only a few that are positive. And I think I know acetic acid is negative. I think Dex is positive, if I remember correctly. It's been a while. But if I put the negative pad on my lateral epicondyle, there we go. The best option would be to put the positive pad on the opposite side so it pulls. But in theory, you could put that positive pad anywhere. I mean, all that is completing the circuit, right? Think about your car battery. I don't know if any of you have ever jumped a car battery, but if you hook up the little clips to the other car that's jumping you, and then you only hook up the positive to your terminal, nothing happens, right? Your car just sits there and is like, yo, what? Nothing happens until you click both of them on and complete the circuit. Now that you're completed the circuit, your battery is getting juice. Now you can crank your car and start it, right? And just like your car, when you do that, you may have to wait a little bit, right? It may take a little bit before the patient's feeling anything. So the first time you do, obviously, Ionto, you may want to observe them the whole time. Most of the Ionto machines we have nowadays, the nice part about them is they're set it and forget it. You put it on the patient. It's a little patch that just goes on. It has a little unit that attaches to it. They go home. It's really easy nowadays. But so remember, the key thing with this is most of the questions on Ionto are going to be safety related. How do you reduce an adverse reaction? Or what do you do if you see an adverse reaction? And that should be simple, right? You come and observe the patient and you notice that the whole area around the pad is bright red, right? What should you do? If you notice the area around the pads are bright red, turn it off. Yeah, there you go. That's it. Turn it off, take it off. Right? What could cause a reaction with Ionto could be the e-stim itself, right? They could be having a reaction to the stim charge in. Or the other thing is, could be a reaction to the medication, right? Maybe they don't react well to acetic acid. Yeah, exactly. Good job, Dara, right? Some people don't react well to acetic acid. And even though it's like, you know, when we think about acetic acid, I've talked about this as white cider vinegar. You know, they may be able to cook with it, they may be able to eat with it and stuff like that, but for whatever reason, you put it on the skin and it causes a really bad reaction. Okay, well, we can't do that anymore, right? And no amount of adjusting the Ionto is going to affect an allergic reaction. They just are allergic to it. I had a patient once that was really weirdly allergic to dexamethasone. So much so that even if you got a little bit on them, they had a really hyper reactive sensitivity to it. It was really wild. Like he didn't even want to be in the room when somebody was on. I don't know if you ever saw people that were like paranoid about peanuts. You know, I don't want to be in the room if somebody's eating a peanut. Same idea here. So ultrasound, we're going to jump to ultrasound now. All right, let me go. Are there any questions on e-stim before I move on to ultrasound? Did anyone get anything on e-stim that they didn't? That help a little bit? I hope. Maybe just get one yes. That'd be great. All right, cool. There's one yes. All right. Moving on to the other modality I question on, ultrasound. So just like with e-stim and with IFC and TENS, I have kind of a tree I follow is what I call it. Ultrasound, I have a tree I follow too. When I get an ultrasound question, the first thing I look at is, am I looking for heating or am I looking for healing with my ultrasound question? So heating would say something like the low back is tight. Your paraspinals are sore. It's dealing with the muscles, right? The patient has tight quads. The patient has tight rectus femoris. Those type things we're going to deal a heating response to. A heating response is a continuous. The machine is going to be on 100% of the time. Versus talking about ligaments. The patient has an ACL tear. The patient has an LCL tear. The patient has a healed humeral fracture, right? Bone repair. Those are a healing response we want to have ultrasound. And those we're going to use the pulse setting, 10 to 50%. I saw the other day that a machine is now coming out with an 80% pulse setting, which I'm not sure exactly why. But hey, maybe there's some research on it. And then your pulse setting itself, and I really don't cover this in here, but your pulse setting itself is going to be determined by the size of your patient and the area you're treating, right? I'm going to use probably a different pulse setting on somebody like Jaira than I might use on Carissa because their bodies are structurally different, right? I'm definitely going to use a different pulse setting on myself than I would use on Erica because Erica's bodies are different than me, right? Tend to, the smaller the size of the area, the smaller the patient, the lower the pulse setting. Because again, when we're working on that healing, the idea is to get those microcurrents and that cavitation going more than it is to heat up the tissue, right? Once we determine whether we're doing heating or healing, the next step I have to determine is, am I going superficial or deep, right? Is it a big muscle that I need to go broad and deep with? Or is it something like the LCL that's right there on that lateral condyle and I can just get to it really easy, right? 1 megahertz, again, remember that with penetration, depth of penetration, it's inversely proportional. So depth of penetration, the lower it goes deeper, right? So 1 megahertz gets a deep penetration, 3 to 3.3 is a superficial penetration. That also could be based on your patient. Now, they're not going to give you a question where they're like, your patient has a really small body frame and we're working on the paraspinals. Now, paraspinals are pretty much always a 1 megahertz penetration. Gastroc, 1 megahertz penetration, right? Lateral epicondylitis, probably 3.3. Hands, right? Patient has trigger finger, probably 3.3 to 3. And they're not ever going to have a question where it's 3.3 or 3 as your answer. If they do have that on the question, the answer is probably a 1. I'm just saying, because 3 and 3.3 are so close to each other that there's not a clinically relevant change with those. So now I'm going, okay, well, I'm doing a heating response. I want a continuous, and I'm doing it to the gastroc. So I want a 1 megahertz. I want a good deep penetration. The next thing I determine is my intensity, as well as my sound head size, right? So intensity is based upon sound head size. It's also based on the area you're being treated, right? Larger areas or deeper areas, bigger areas, typically 1.5 to 2. Smaller areas are 0.5. I made a mistake there. That should be 0.5 to 1.5. I just realized I didn't copy that right. It may go to 2, but usually 1.5 is about where we cut off for smaller areas. But again, it depends upon your patient, right? Let's say you've got somebody that's really sensitive to ultrasound. So Jaira comes in and he's my patient, and I'm doing ultrasound to his low back, and he reports, I have it at 1.5, and he's like, man, that's really doesn't feel good. I don't like that, right? We may either discontinue treatment or turn down the intensity. Even though we said, well, we start at 1.5, Mr. McKeever, we still can turn it down, right? But let's say we've got him as my patient, I'm at 2 megahertz or 2 watts per centimeter squared. And he's like, and I don't feel anything. Can you crank it up some? I personally don't like to go over 2 watts per centimeter squared. I know some clinicians will go up to 2.5. I just don't like to do it because I really put myself at risk of doing what to the patient, especially if you're doing continuous. What could you do with a continuous ultrasound higher than 2 watts per centimeter squared? Potentially, yeah, burn. Right? And just had a clinic that I know down in Tucson contact me, and they were doing ultrasound on a patient. They were doing underwater ultrasound, so hand in the water. The tech had the setting at 1 megahertz, continuous, and set the ultrasound setting to 3.0 watts per centimeter squared. Because the tech wasn't trained on how to do ultrasound. So she just cranked up the intensity. And now that patient that had trigger finger now has a 1st-degree burn in the majority of their palm. Right? That's what separates PTAs from techs. Yeah, right? Seeing that a lot. Exactly. So that's and if you look at the laws here, not the laws, but if you look at the lawsuits here in Nevada, majority of the lawsuits that happen in Nevada are people that are untrained using modalities they shouldn't be using, causing bad effects. Right? So just kind of think about that. Again, your safety wise, if the patient says, ow, that's burning, stop the treatment, look at the area, look at your machine, right? what else other than your settings could cause a burn on the patient on the ultrasound head? Because that could be a question. So your settings are low, but the patient's still complaining about really bad tingling and burning when you're doing the ultrasound. What could be the problem? What could be damaged? The sound head, right? What's specifically in the sound head? What's in there that actually sends it? The crystal. Yeah, right? Sometimes that crystal gets cracked or gets damaged to it, specifically if somebody drops the sound head. It will cause a really weird feeling to the patient. That when I've had that happen once I've had it once in my career that it's happened. I put the ultrasound head on the patient, and the patient's like, "Yo, what was that?" And it basically he said it felt like I was stabbing him with a knife because the sound waves were going in at a really sharp angle. And he's like, "That I've never felt that before." And sure enough, I talked to him, and somebody said, "Oh yeah, I dropped the sound head yesterday." That'd have been nice to know, right? That's why we're protective of the sound heads. So that could be a question. Yeah, that's probably what he described. And he just said it was like, actually, he said something to that effect. It was like feeling like getting a tattoo is a good way of looking at it, right? It just felt like suddenly all that energy was delivered in one little micro spot. And he did not like that, right? And so what I do, take the sound head off, tag it, put it away. We don't want to use that sound head anymore, right? Until it's inspected. And there are ways that we can actually self-inspect them by looking for cavitation in the bubbles, but that's not a test question. So, that would be a question if you get on your board. So if your patient notices that it's uncomfortable, what do you check? Well, number one, check your settings. Number two, check the sound head. There's your two easy ones there. The sound head size is determined by the ERA of the sound head, right? Effective radiating area of the sound head is found on the tag. Your treatment area, this is a common test question. Your treatment area should be 2 to 3 times the ERA of your sound head. So if you have something like a 16 square centimeter area that you're treating, you want something that maybe is a 12 to a 20 ERA sound head. So your treatment area should be about 2 to 3 times the ERA of the sound head. The BNR is how coned or columned the ultrasound is. Lower BNR is better. So what that literally means is if I have my ultrasound head here, and again, you have that tag, right? There's the tag with all your information on it. That's supposed to be a tag. Ignore me. There's your cord. Your BNR will determine how either columnated, right, in a column, or how coned their treatment is. The lower the BNR, the more the ultrasound delivers in a solid cone, right? Standard BNR is about 2 to 1, meaning that if the ERA is, say, 4 centimeters, it's going to column out about 8 centimeters, right? 1 to 1 is most ideal, but I don't know that there's any ultrasound manufacturer that makes a 1 to 1 sound head. I know BTL is pretty close. I think theirs is 1.5 or 1.75 to 1. But the BTL ultrasound heads are really super expensive, and you're in a lot of hot water if you drop one of those sound heads. So the BNR is determining how wide that ultrasound goes out and how much it affects the surrounding tissue as well as the area you're treating. The only other thing I don't have on here that I just happen to think of is how fast do you want to be moving the ultrasound head in order to prevent burns? You guys remember that? How fast? Ooh, I might assign that as a 2 centimeters per second. Okay. Anyone vote to agree with Adrian, or we vote him off the island? We all agree with me. Okay. So, well, here's my deal. I'm going to assign that as a little homework. I'm not actually going to answer that. I want you to go back at some point. So put that down to go review that, because that tells you one thing you got to review, right? I could review it, but I got to let you guys do a little bit of the work because I did all the work for this PowerPoint. So I want you to review it and get back to me. Any questions on ultrasound other than that question, which I'm not going to answer? I will tell you this, ultrasound speed is similar to ice massage speed. I'll give you that. Any other questions on ultrasound? We good there? Okay. Pathophysiology. This was one that I found rough kind of reviewing, right? It's going to vary based upon the disease. When you're prepping for the exam, in score builders in the back of each chapter, there's gold content and silver content areas. Focus on the pathologies that are in the gold and silver content areas. There's no possible way I can distill pathophysiology down to one session. You know, if there's specific diseases or specific disorders you want to discuss in a future session, I'm willing to do that, but there's no way I can distill all of patho down here. So the best information I can give you on this is look at those gold and silver content areas in your score builders book. And if there's something that still you aren't getting, like, man, Mr. McKeever, I'm not getting myasthenia gravis, send it to me for a future session. I didn't get any specifics. Like can we review all of pathophysiology? There's just no way I can review all of patho. That would be a multiple session. I can do multiple sessions on certain diseases, but there's just no way I can review full pathophysiology in one session. It just isn't feasible. I thought about it last night, trying to come up with some way of doing it. There's really not. With pathophysiology, I will say this, most of your questions are about safety again, right? What is the most safe method to ambulate a patient with myasthenia gravis? What is the most safe method for patients with Parkinson's? So if there's one of those diseases, that you want to talk about in the future, please just email me that specific disease so I can put a little slide together on it, because otherwise I can't review all of patho. There's just no way. It's just not possible. I'm sorry, guys. I'm great, but I'm not that good. Right. So, and I know I got one from somebody that asked to talk about myasthenia gravis versus something else. I put that down for a future session because I didn't have time to write something up nice and neat about that last night. So I put that down for the next session, and we will review it. Oh, they want to know the difference between myasthenia gravis and Parkinson's, because they were looking at it and they were very similar, and they are pretty similar. So I put that down for a future session, but there's just no way I can review all the patho. I'm sorry, there's just not. I know you guys think I'm great, but I'm just not that good. Capsular patterns. I believe this was a gyra concern, right? Capsular patterns go with arthrokinematics or osteokinematics. Which one? I actually just taught this yesterday. Right, arthro, right? It is the joint capsule, right? Whereas osteo is our measurement of goniometry. So I put together this little chart, try to distill it down as much as possible for you. If it has a little equal sign, that means there's equals loss of them. So like with the wrist, it says flexion, extension, there's equal loss. If a patient has the key thing for this, if a patient has a capsular pattern, what are we going to do to them? What does capsular pattern tell us to use for treatment? Joint mobs, yeah, exactly, right? If the patient presents as a capsular pattern, joint mobs may be a valid treatment for this patient, right? If they are a non-capsular pattern, they're probably not going to respond to joint mobs, right? So if I am, like in the case of, let's look at, where is shoulder, right? So in shoulder, there's internal external rotation loss and abduction loss. If my primary problem is flexion, it's probably not the joint capsule. Now, does that mean that we're not going to do joint mobs if the PT tells us to do joint mobs? No, right? The PT may have a logic reason why they're doing joint mobs, and we may ask that, right? But I love it. Amanda went looking. She was like on this. She just had that class. So in the case of, so technically you're right. Technically you're right. Yeah. In the case of joint mobs, if the patient doesn't have a capsular pattern, they're probably not going to react well. And some PTs actually aren't so sure that capsular patterns even exist. Right. So I won't even argue that concept because that's a whole nother concept in itself. So if I have a problem with my shoulder and you notice my internal external rotation are messed up, right? So my in and X are messed up, and I've got a lot of abduction problems, you're leaning towards capsular pattern. And then what you have to figure out is which capsule am I going to do the pattern on? Which one am I going to actually do a mobilization on, right? So then you think about it. Let's say that I'm limited more in external rotation than in internal rotation, right? So I'm here, I'm limited more in external, right? If I go into external, what capsule is being stretched? Which part of the capsule? The front or the back? Put your hand up in your shoulder right now, right? Go into external rotation, see which one you feel is tight. Ooh, yeah, that anterior capsule's tight, right? Yeah. So that means I'm going to do what type of immobilization? To stretch that out. Post-ant, right, good. Right, because I'm going to come here and I'm going to really push and stretch that out. So those are the type of questions they can ask you about mobilizations. They're not going to ask you, can a PTA do mobilizations? They're going to ask you kind of that type of theory. So that's when you're going to get in your little cubicle, you're going to slide in as far as you can, and you're going to be going, okay, oh, there's, I feel it now. And make your decision based on that. Does that make sense? But this tells you what is a capsular pattern. If I was a betting person, the ones I would bet you're going to get capsular pattern questions are the shoulder, the hip, the knee. Because those are the big capsular pattern joints, right? And the knee, primarily, what are we mobilizing? What do we primarily mobilize in the knee anyway? What's the main problem that needs mobilized? The patella, yeah, right? Patellar mobs. More than likely, it's the patella that's limiting the knee because it gets bound down underneath, especially after something like a total knee replacement or a ACL repair. So those are what your capsular patterns are going to lead you to do is, again, if you notice capsular pattern, you're probably going to mobilize the joint. Now, let's say, I'm going to go back to the shoulder, and my problem is I have extension problems. I can't reach back. If it's not capsular, then it's probably what? If I'm having a problem with extension, that's not a capsular pattern. What's probably the problem? What could be the problem? Let's go that way. Could be muscle tightness. Good, right? Could it also be a bony block? Yeah, right? And let's think about that for a second. Patient's got a bony block. You've got a hard end feel when you're not supposed to have a hard end feel. That can be good to mobilize. Nope, right? Yeah, we might damage muscle. So that's why capsular patterns are important. Does that help, Jairo, with the capsular patterns? Having a nice little chart to kind of look at for it? Right? This just makes it, I tried to distill this down as simple as I could. But if I'm going to be that betting person, I'm definitely remembering my capsular patterns on my shoulder, my capsular patterns on my knee, and my capsular patterns of my hip and my knee. Does that mean you're not going to get a wrist question? No. But the likelihood, again, remember I talked about this, the likelihood of getting a hand and wrist, right? Yeah, you'll get some radial ulnar ones, but most of those are, most of the ones I've seen on that are safety related. Or if you should do it, right? Now, what if you get a question that says the patient is having some capsular pattern of the T-spine and the PT has ordered you to perform grade 5 mobilizations posterior to anterior? What should you go down and look for in the answer? Right, you should go down and look for no, or what you'll look for is out of my scope of practice, consult with the PT. Right? And that could be the PT doesn't understand it, but what they're looking for is they're looking for you to understand that grade 5 mobs are out of your scope of practice. That one is 100% given. Right? Grade 5s, we do not do. I'm going to be honest, I know PTs that won't do grade 5 mobs. Just because they know that thrust mobilization, you know, while it feels good, right? We all love it when we crack our backs or crack our necks or crack our knuckles or whatever. You get that kind of that auditory, ooh, they're worried about it. Right? They're worried they might actually injure a patient. So that's capsular patterns, literally in a chart. Muscle actions during gait. I broke it down into a couple slides here for you guys. So talking about initial contact versus loading response versus mid stance versus terminal stance. I want to say it was Sukana that asked about this one, if I remember correctly. Yeah, it was Sukana, right? So I tried to break it down from my lecture of what muscles are going into what. The main thing I had with these when I was actually doing these questions on my boards is I, again, slid into my cubicle and I did whatever position it was asking me about. So if it was asking me about initial contact and what are the dorsiflexors doing, I got in my cubicle. I thought, okay, initial contact's when my heel's touching the ground. What are my dorsiflexors doing? Okay. Oh, okay. So they're going to be controlling the neutral aspect of my ankle, right? What are my knee extensors doing? Oh, okay. That's what I'm doing, right? They're contracting the chain knee extension, and then they're eventually going to go eccentric. I would get in the position that I was doing in gait. You cannot get up during the test and start walking around the room. You just can't do that. So you have to get your little people in. I use my fingers a lot. I was like, okay, initial contact. I'm there. There are things you do, or draw. If you're a drawer, draw, right? Get out your little whiteboard they give you and draw somebody making initial contact, or maybe mid stance. Oh, they're in mid stance, so their foot's straight. Their knee should be straight. This little chart here, or this little kind of loadout, is a good way to study for that. I could read through all of this, but honestly, I think the better thing would be for you guys to read through it yourself and see if there's any questions you have on it. And if there are specific questions, I can answer those. But I think this will help get through the concerns about muscle actions during gait. I did also put together kind of looking at that, the difference between traditional versus RLA scale here for you guys. So what does it look like with initial contact? Initial contact is the same as heel strike, right? Remember, what is the difference? What's RLA versus traditional? What does RLA typically take into account? Do you remember what I said about this back in Kines? When I think about these, I think of RLA as more the neuro side of it, right? And I think of this as more the musculoskeletal side of it, or common knowledge, right? Heel strike, a patient can understand. You start talking to them about initial contact and they have no idea what you're talking about, right? This is definitely more neuro-based. And again, Ranchos, Los Amigos, guess what their specialty is? Their specialty is neuro, right? So that's why it's a little bit more neuro-based. But you may get a question that may talk to you, and I've seen this before, it'll be talking about the patient is having problems with loading response. How does that relate to the traditional gait cycle? The traditional gait cycle would be foot flat for loading response. So you do have to kind of know how these meet up. So that's why I put that in there for you guys to kind of review. I also did the kind of muscle reactions here while we're walking, right? Vertical, the good news is vertical and horizontal displacement with gait is about the same. It's about 2 inches or 5 centimeters. And it does form that kind of sine wave so that as they move, they sway side to side and up and down. In your boards, they may ask you about why is reciprocal arm swing needed? Reciprocal arm swing is needed specifically for energy conservation, right? What type of pathology did I talk about that loses reciprocal arm swing that makes their gait so tiring? Do you remember? Which disease? Where they're kind of hunched over and they walk really quickly. Their feet are a little moving really fast. Parkinson's, yeah. Right? Parkinson's, one of the big things they lose is reciprocal arm swing, because they lose that, they get that dysdiadochokinesia, where they lose that reciprocal movement going, right? And we're going to encourage the arm swing because arm swing will help move them through space. One of these days, what I want you guys to do is, for those of you that are runners, go out and go running, but instead of running with your arms, lock your arms into your side and try to run. You look kind of silly doing it, but try running that way and see how you feel after about 500 meters. You'll be amazed at how much swinging your arms when you run actually helps you run better, because it's for energy conservation. It helps push and pull those hips forward and back when you're moving, right? Think about something like if you've ever been on an elliptical, right? Has anyone ever been on an elliptical and you take your arms off and you just do the other part and it just feels uncomfortable? Well, it's because you're not getting that full arm swing going, which is what the elliptical is there to get you to do. With leg length discrepancy, which I did get a comment from somebody on, the leg length discrepancy less than 3 inches is considered a mild leg length discrepancy, and we're usually going to fall off. Exactly. I tried that once and I just couldn't do it. I was trying for science sake, and yeah, I almost fell off too. A mild leg length discrepancy is less than 3 inches, and we can help them with a heel lift in their shoe, right? A heel lift is what type of a device? Is it a prosthetic or is it an orthotic? Orthotic. Good, right? So that would be a question that you might get on your board. Your patient has a left leg length discrepancy of 1.75 inches. What would be an effective treatment method for this patient? And you go down, there's something that says a shoe orthotic, or one will say a shoe prosthetic. We're not replacing the foot, right? That would be a prosthetic. We're just adding something to the shoe in order to give them a little bit more balance. A moderate leg length discrepancy is 3 to 5 inches. And that we need to address the structural or postural deficits prior to putting a heel lift in, right? So maybe this patient, we look at them and they have a 5-inch leg length discrepancy, right? But their pelvis is like that, right? So it's shifted that if this is the left side, this is the right side, that their left pelvic side is way higher than the right. Well, until we kind of level that out and get the muscular imbalance there leveled out, we don't want to address the shoe lift. Because say we fix this and all of a sudden we get the pelvis back level now, and that leg length discrepancy is gone. And we have a shoe lift in. Now we've created a leg length discrepancy, right? So we have to make sure we address the issues first before we do the orthotic, right? And then anything greater than 5 may require surgery. And again, at that point, you're not going to get a question typically on those, but anything greater than 5 is considered severe or marked, right? At that point, they need to see an orthodoc about it. Sometimes with kids, they'll let it go and they'll monitor it, because they may grow out of it, because kids grow. I don't know if you guys know that or not, but kids do grow. They don't stay like baby-sized forever. And the other question I got was on pronation supination, right? Pronator or an overpronator is most of the population. We trend towards this, right? 90%. Some pronation is normal during gait and running. That's actually kind of what we want. That walks on the inside of the foot. A moderate amount of pronation is normal. Supination is the least popular of the population, and this is where we may want to treat them for it. This is where they walk on the outside of the foot, and how can you tell if the person's got a pronation? Take their shoe off and look at their shoe. If you have somebody that's a heavy supinator, like I'm a heavy supinator, you can clearly see on the outside of my shoe that I've got almost no tread left, because I walk on the outsides of my shoes. That would be one that we might have to address and work on, maybe subtalar neutral a little bit better while they're walking and running and keeping their feet more normal. It will be, it's going to be posted, Adrian. Don't worry about it. So that was, I think, all the questions. I did put the different gaits in here on one chart in case you wanted to review that. I didn't have any questions on that, but I wanted to make sure that I put these on here in case anyone ran into that and they were having problems remembering what the gaits were called. Remember, the only one that Mr. McKeever kind of doesn't like is this one here. Patient presents with right antalgic gait pattern. That tells us that it hurts when they walk. Great, they stepped on a Lego, right? It doesn't tell us enough about the patient to really know much. And I honestly, I saw that more in the hospital than I see it in the outpatient world, where like today patient presents with antalgic gait. Okay. Why? Right? If you're going to put antalgic gait in it, put why. Today patient presented with antalgic gait due to increased sensitivity of compartment syndrome of the right lower leg. Okay, now there makes more sense, but just saying antalgic gait is like saying water is wet, right? Patients are in pain. That's kind of why they see us, right? They don't, I mean, at least in the United States, they don't come to us and be like, hey, I'm feeling really good today. I'd like some PT, right? That's not the way it works. They come to us because they're saying, every time I run, my knees hurt. That's why they come see us, right? That's mostly why patients see us here in the United States. But this is just kind of a gait deviations in one chart thing for you. Forward head posture. I think this was Carissa that asked about this. I did a couple slides on this, and after Chris asking, I've changed a little bit when I talk about this in the C-spine lecture in kinesiology. So I'm going to add a little bit more to this for it. Forward head posture. Who has forward head posture? Yeah, like I do, right? Pretty much everyone lately, right? And I just sit here looking at myself in the video and I'm like, oh, look at that, right? Can you guys see from the side profile my forward head posture? And that's at relaxation. I can actively sit up straight and get it right. There we go. But I have to actively think about it. But when I go into rest, I kind of get that forward head posture. Why? It's a learned, for me, it's a learned ability, right? Could it also be structural? Sure, it could be, right? And that's why I have snaky head back here, because that way I kind of think about sitting back and putting my head on snaky, because snaky makes me want to go to sleep. So normal line of the head with the reaction of the thorax to the lateral view is a vertical alignment of the external medius with the acromioclavicular. So if I'm going to sit here, right? So I'm going to sit up nice and tall and sit like I normally do. Here's my acromion. Is it in line with my external auditory meatus? Yeah, no, right? Could be geriatrics, definitely, especially Parkinson's. Parkinson's patients are way forward head. The main thing with forward head is, what's the patient going to experience because of it? Right? Well, they're going to experience a sore neck. That's going to lead to headaches, right? That can lead to, if I've got a problem up here in my C-spine, right? That's going to translate down to my T-spine. That's going to translate down to my L-spine, which will translate down eventually to my sacral region, right? That's the thing with the spine, is once you affect one part of it, it kind of propagates down the whole spine, doesn't it? Right? If I increase my lordotic curve up here, my body's going to try to correct it back here, which will try to correct it down low, which will try to correct it down lower, and it'll mess up my whole posture. So with forward head posture at the joints, you have increased flexion of the lower cervical spine and upper thoracic spine, right? Flexion forward. You have increased extension of the occiput on the first cervical vertebrae. So my head's going to shift backwards, right at the AO joint, the atlanto-occipital joint. And I'm going to increase extension of the upper cervical, or what we call the capital spine, right? So I'm going to get kind of extension up here, and I get this. And when you get something that's really bad, you can start seeing those SCMs and the platysma coming out, right? So the structures that are going to cause pain, well, the ALL is getting stretched at that point, right? Remember, on the front of that spine, here where we have it, we have that broad anterior longitudinal ligament. And that anterior longitudinal ligament is one of the thickest ligaments in our body, and the job is to keep the spine in the spine and out of the organs, right? That's why it's so hard to have that anterior dislocation of the spine. So that's going to get all kind of worn out. It's going to become elongated, right? And then the posterior longitudinal, if this becomes elongated, the other one's also going to get kind of worn out as well. So the posterior longitudinal ligament is going to get worn out. Here we get a great picture of this here. Look at this. Look how bad this forward head is here. This is a great X-ray, I thought. right? Look at, I mean, that's just, that looks uncomfortable, right? And now look at the space here between those vertebrae, right? There's not a lot of space. And so everything's kind of getting squished. So the disc pathology is going to develop, right? They may develop TMJ. I'm going to change this. I didn't update this because I've been trying to. TMD, because I'm a big believer when a patient says, I've got TMJ, that I'll look at them and go, wow, I've got 2 of them. You only have 1? Just joking. I don't actually say that, right? Because TMJ is just the temporomandibular joint, right? TMD is temporomandibular disorder. That's where they get problems with the temporomandibular joint. This is probably why I should never practice again. No, I'm just kidding. So they get some dysfunction in that temporomandibular joint. The facet joints in the upper cervical spine are going to get problematic, right? You have approximation of the joint surfaces, we're on positional narrowing of the intervertebral foramen. Once we narrow those foramen down, we start getting pinches, right? And we get nerve root impingement. That was one of the major reasons I had to have surgery on my spine, was because when the neck broke, it had literally obliterated my left nerve window. And when it did that, the nerves were just getting completely cut off and my arm just went dead, right? So it's going to cause nerve root impingement. Muscle-lunar imbalance, right? The posterior cervical muscular becomes shortened and the upper cervical muscular becomes elongated, right? So all of that's going to become weak and over tight and everything's going to become nasty. And that muscle tension is going to develop the fatigue and the pain, right? And a lot of them are going to say, man, just when I'm sitting at my desk, right? Patients, these are the patients that are working at a desk, or even in Vegas here, are the patients that are dealing cards and stuff like the dealers, right? They're out there dealing and they've got that forward head posture going on. Like, man, every time I'm working, my head just hurts. I don't know what's causing it. So you do an occupational review of them, and when they're sitting there dealing, they're like this. Well, gee, I wonder why, if my head's like this, why I'm getting a headache, right? So you may get tight anterior scalenes and impinging on the neurovascular bundle, tight levator scapulae and impinging on the cervical plexus, tight upper traps, impinging on the greater occipital nerve, right? A suboccipital triangle, that's the one we do. What's that treatment we do for a tight up suboccipital triangle that patients love? And some of you love too? Yeah, suboccipital release, right? Where they just sit there and like, oh, I love you now, therapist. You are the most wonderful person in the world. I shall write songs about you. I will toss a coin to my witcher. And the SCM is going to become short. And when the SCM comes short, what else could they possibly deal with? What other condition may come along with this? If the SCM starts becoming short? What's that called when the SCM gets short and your head gets twisted? And babies get it? Torticollis, yeah, right? So we may be looking at this going, okay, this could be a chicken or egg situation here, right? Because maybe the forward head is caused by the torticollis, or maybe the torticollis is caused by the forward head. And that's why the PT eval is so important, right? They're going to go through this and go, chicken or egg. I'm going to pick one of them to treat. So all of it comes into play with that. So we're going to actually look at that and kind of see which one we're going to treat. We have to treat both, right? So we're going to stretch out that cervical spine, get them back in here, right? Doing chin tucks, or as I call them, chicken tucks. You look like an angry chicken coming at you, right? So this is kind of looking at the muscular side of it. What we're looking at, here's that suboccipital triangle over here. And again, you don't realize those muscles are super duper tiny. They're not really huge muscles. But man, when those things get tight, they cause some major problems, because you got those greater occipital nerves passing back here that go up to the dorsal part of the dorsal part of the scapula. Not scapula. Wow. Dorsal part of the skull. There we go, Keith. Wake up. And so then they pinch down on that. And you're like, man, I'm getting this headache that's just going like this, right? And they're talking about it, and you have a tension headache, right? Or maybe the scalenes, right? The anterior and the middle scalene get pinched. And so now that neurovascular bundle that's passing out gets pinched. So all of that can come into play, right? They may end up developing something like thoracic outlet syndrome because of their forward head posture. So all of that comes into play with forward head. Does that help with forward head, Carissa? Will that help you a little bit in reviewing it? Look through those slides. You still awake, Carissa? I'm going to say she says yes. All right, upper motor neuron versus lower motor neuron. When are we dealing with this? What type of patient are we going to be worried about upper motor neuron versus lower motor neuron injuries? Primarily. Oh, Krista got kicked. Could be ALS. Okay, good. Yep, you're right. I didn't think about that one, but yes. What type of an injury are we going to be dealing with this a lot? It's occurring in the spinal cord. Yeah, spinal cord injuries, right? Good. Right? So the upper motor neuron injury occurs before or above the level of the anterior horn cell. So my anterior horn cell is right in here. So if you have an upper motor neuron injury, I like to think of an upper motor neuron injury as more CNS related versus lower motor neuron injury occurs after that anterior horn cell. So that is PNS primarily, peripheral nervous system, right? Now remember, with a motor neuron injury, does that include sensory problems? Not typically, right? We're just talking about the motor neurons. Could they have, yeah, I could have a spinal cord injury where I've got both my sensory and my motor neurons cut, right? But what I'm talking about with upper and lower motor neuron is just looking at how this motor neuron fires. Okay? So the key there is, and I've seen questions on this on the boards, is how do you determine if it's an upper or lower motor neuron injury? Where does the injury occur? Does it occur before the anterior horn cell or does it occur after? And then your symptoms come into play, right? Because this is their presentation. This is how you know if they have an upper motor neuron or a lower motor neuron injury. So an upper motor neuron injury, again, a more CNS-related patient, they end up with hyperreflexia or overactive reflexes. So if I have an overactive reflex, my DTRs are going to be really active. So my deep tendon reflexes are going to be just simply boss. They're going to be kicking off if I fire them. So I tap that patellar tendon and that leg is just like wham and just pops up like it's nothing, right? They're going to have a positive Babinski. We learned about that when we talked about deep tendon reflexes. That's kind of that most basic deep tendon reflex that integrates and is a baby. And they're going to end up with Clonus potentially, right? And Clonus is, what's Clonus look like? Do you guys remember what I talked about with Clonus? If I had Clonus in my hand, what would my hand be doing? It'd be doing one of these, right? So like say you got somebody that's got Clonus in the hand, you extend back and they just kind of can happen with the Babinski, right? Can happen with the plantar reflex. Could happen with patellar reflex. You tap the patella and the leg kicks up and just sits there and quivers, right? And you tell the patient, hey, can you stop that? And they're like, I am, right? Because it's a CNS response that's causing it. It's not actually them thinking about doing it. They will eventually end up with disuse muscle atrophy. Well, they end up with disuse because they'll stop using those muscles because there's no nerve response to them. You may get those little fasciculations or those microfibrillations, or you will get them that are absent. They will end up being hypertonic to spastic. And it will be velocity dependent, meaning that they'll they typically become like clasp knife or really tight spastic. And the more you try to pull them out of it, the faster you try to pull them out of it, the more that spasticity will fight you. I'll talk about that in a second, Tara. Because we'll actually, because that's the difference between, severe waste. That's basically the difference between severe wasting and disuse, right? So spasticity is velocity dependent, meaning that if I pull slow and stretch them out slower, it's going to be better. So a question on the boards could ask, you have a patient that has an upper motor neuron injury with spasticity. The best way to stretch them is low and slow. You wouldn't want to do a ballistic stretch on that, because if you try to do that ballistic bouncing stretch, it's going to kick that spasticity into high gear. And they're going to lose autonomic control of their muscles themselves. So they're going to lose that just normal function, right? If you have a really high level motor neuron injury, typically a lot of times they're going to be complete spinal cord injuries, and they're going to lose autonomic control of bladder and bladder, right? So upper motor neuron above. And so Jaira asked, what's the difference between disuse and neglect? So neglect is a form of disuse, right? So disuse is when you stop using it because there's nothing going to it, right? But neglect itself is there's something going to it, but you're ignoring it. So something like a stroke gets neglect quite frequently, right? I still have my arm and my leg, but I go, I don't have it. Oh, the NPTAE is calling me for money. Does that make you got it? Okay, good. Versus that lower motor neuron injury. So now the cut doesn't even come from the spinal cord at that point. It's beyond it, right? Now they have almost no reflexes, or hyporeflexic. So you tap that patella tendon and nothing happens, right? You almost get no deep tendon reflex. You may get really minor, but typically you get nothing. They will have no Babinski reflex, which in a normal human being is normal, right? Normal is normal here. They'll get neurogenic muscle atrophy and severe wasting. Well, why is that? The nerve's dead, right? The nerve is cut, and it's cut off from the spinal cord entirely. You may get some fasciculations, some fibrillations. They will go hypotonic to flaccidity, meaning that like I got. So my injury was a lower motor neuron injury to my left arm. Within about 6 weeks of my injury, this arm was completely flaccid, right? It looked like a wet noodle. I had it in a, what do you call it, a sling? But if I took it out of the sling, the arm just dropped. And I could pick it up, and that was like my party favor. I could pick it up, and I looked like the, what's that thing that the wavy man that the car dealerships put up? Right, that arm was just kind of wavy in the air. It didn't do anything, right? The key thing is with both of these patients, whether they're upper motor neuron hyperreflexive or lower motor neuron and hyporeflexive, they will eventually both go or they will eventually all end up kind of spastic and tied up if they get no treatment. They're going to all end up kind of back in that decorticate posturing if they get no treatment, right? And that's kind of sad. And we had one case that here in Nevada where the patient came in after having a spinal cord injury. I want to say it was like 15 years before we had seen them, and they had no PT. And they had a definite lower motor neuron injury, but because they had no treatment, the arm eventually was up like this and just completely and utterly contracted. And, well, can you help my dad and help him get back to moving that arm again? Well, it's been 15 years since he's used that arm. That's going to be rough, right? So that's upper motor neuron versus lower motor neuron. This chart is probably the main thing. One of the things that helped me, because a lot of times they ask you about reflexes with this. One of the things that helped me remember this is I have a lower motor neuron. So they are hyporeflexive. Lower hypo. Oh, these are the weird things that I did when I was doing it. Right, it does. Yeah. So Chris asked, so we focus on stability for hypertonicity and hypotonicity. We focus on more ballistic. Well, if you have hypotonic and it's completely flaccid, they're not going to need stretched until they really get later on in their injury. Because it's a wet noodle. They're completely stretched out as it is, right? They're just a giant ball of putty for you. Right now, the longer they go, the muscle's going to waste away and contract up. right? And at that point, there's probably nothing you can do for it at that point, or very little we can do, because they just wasted that long, right? But hypertonicity, we're going to do low level stability type stretching, definitely. So I remember that lower as hypo, they both have O's, right? That was my way of remembering that part of it. And then if I could remember that, that helped me remember most of the rest of it, because if I know they have no reflexes, they're going to go flaccid. So that kind of was my memory of doing that one. Any questions on that, Jared? Does that help you with that issue that you had? Okay. Synergy. So this is that thing that I kind of talked about a little bit and stuff like that. Synergies are mass movement patterns that are primitive in nature, relating back to pediatric reflex, that couple with spasticity due to brain damage from something like a CVA or a TBI. When CNS is damaged, the higher levels of the brain that control higher functioning fail at inhibiting these primitive patterns, right? So that integration that you had as a kid now becomes de-integrated. And you end up with these real primitive, basic pediatric reflexes that come back. The higher level centers lose control, and the loss of control presents a stereotypical pattern in the upper extremity and lower extremity. So this is where we talk about that decorticate versus decerebrate posturing. Remember that? So if I've got a really bad traumatic brain injury, and I just saw one the other night. Let's see if I can find the video. Actually, I know I have the video. I'll show it to you. It was from a hockey game. It was the Blues and the Avalanche, I think it was, that were playing. And a guy gets hit from behind. And when he goes down, because he gets hit in the head, as soon as he goes down, he goes into corticate posturing. His arms come up and he's like laying on the ice like this. Right? We know that's bad. Right? If he instantly goes into corticate posturing, that's a lot of damage to the brain. Right? That's the brain trying to protect itself, basically saying, okay, I need to bring my whole body in to protect it. So remember, with decorticate posturing, would decorticate, which looks like this, be flexion synergy, or would that be extension synergy? Flexion synergy, right? Because decerebrate, they go like this. So that's an extension synergy. Right? So decorticate versus decerebrate posturing. And the way I always remembered that was, let me get up my little writer here. So decorticate, I know I'm going to spell decerebrate wrong because I always spell it wrong. Decerebrate. Maybe I spelled it right this time. The way I always remembered it, so this is more of a flexion synergy. It's more of an extension synergy. I looked at core, pulling to the core. That is my flexion synergy. Whereas decerebrate, extension, it's got an E in it. So they're going to extend back. Right? And all has to do with the brain injury and those primitive reflexes. So these are kind of looking at what the body looks like in a flexion synergy pattern versus an extension synergy pattern. Some of them end up being the same. Like the fingers themselves in both decerebrate and decorticate and flexion synergy versus extension synergy, the fingers flex and adduct. So they close up. And that looks a lot like baby, doesn't it? Right? Baby's fingers are typically kind of curled up and not really wide when they're in protective mode. Same idea here. So in flexion synergy, right, my scapula becomes elevated, retracted, my shoulder becomes abducted, externally rotated, and flexion. So I end up like this. And supinated, wrist gets flexed, my fingers kind of curl up, and my wrist kind of curls up. Extension is the reverse. So I put these two charts on there for you, but the main thing with this is, if I've got somebody that's in flexion synergy, what do you think my goal is going to be for posturing? In order to prevent contractures. So yeah, I'm going to try to get them to extension synergy. Exactly. Right. So I'm going to try to do the exact opposite. So if they're curled up like this, I want to get them out, because they stay like this long enough the muscles are going to contract and they're going to be stuck here. Right? No one wants to look like the bunny rabbit hopping down the road. Right? So that's the kind of the part of with this. Did you have was there anything specific you had? I know, Jairo, I think you were the one that sent me on this. Was there anything specific that you had on this, or is this kind of what you were looking for on it? That help explain it for you? And if there are specific questions on any of these, yeah, that's why I prefer doing little snippets like this, where it's just what it is. So flexion synergy or synergy is just brain no worky, and it's either going to pull into the core or push away from the core. That's the way I looked at it. Brain no worky. That's my technical breakdown of it. I think that was all I put together for this one for this day. Let me see. Yeah, it is. All right. How was that? Was that a good review? That helped you guys a little bit? I know that was like an hour and a half or so. So here's what I want for you guys to do. If there's more things you want to review, like I said, with pathology, it's impossible for me to review all pathofits. I can't. I just can't. Right? There's specific diseases. You're like, Mr. McKeever, I want to review Parkinson's. Or Mr. McKeever, I want to review congestive heart failure. You know, because I'll bring in Dr. O'Neill for stuff like that. Or, you know, anything along those lines. I will bring in everyone to help me out with this. Email me, because that way we can kind of add it to the slate and I can start prepping a little in advance. Some of you guys emailed me a little bit yesterday, so I had to put stuff together really quick. The good news is most of the topics that you guys are going to ask me questions about, I've already reviewed previously, so I just had to kind of pick and pull my stuff. Okay, so Jared asks, okay, so I have one more question. How in depth do we have to know about the Asian impairment scale and the Bobath NDT? Well, so here's the deal. I'll tell you about the Asian impairment scale. Is really easy. It's nothing more than deep tendon reflexes and your manual muscle testing. I would say more than knowing 100% about the Asian, you have to know what the Asian impairment scale is, first of all, right? That's the impairment scale for spinal cord injury patients. The other thing is knowing your nerve roots, because that's what it all traces back to, knowing your dermatomes and myotomes. So that's the main thing with the Asia. With Bobath NDT, you're not going to have to know a ton. The Score Builders has a really, really good section. Yeah, has a really, really good section on Bobath on that. Just read through that. You're not going to have to know totally in depth about Bobath. Let's go that way. Are there any other questions? I appreciate you guys stopping in. Like I said, we're open. We're going to do as much as we can for you guys. Keep pushing forward on your studying. I know that several of you message me 2 to 3 times a day sometimes. Chris does it once a day. I was thinking about Clarice. Clarice does it about 2 to 3 times a day with me. So if you guys need anything, I'm here. If I don't respond immediately, it's because I'm in class, but I will respond. Also, Dr. O'Neill's there, Dr. Ovreskin. Use all your resources. We're all here for you. If not, I'm going to stop recording now. Now I'll stop that.